welcome to DTalk, the podcast series of the International Diabetes Federation that brings you real stories, expert insights, and innovative solutions from the global diabetes community. I'm your host, Dr. Phyllisa Deroze, and today we're focusing on diabetes-related eye diseases, one of the most common complications of diabetes. If left untreated, high blood glucose levels can damage blood vessels in the retina, leading to vision loss or even blindness. The 11th edition of the IDF Diabetes Atlas presents a complex picture. Approximately 30% of people with diabetes show signs of retinopathy, but only about 10% progress to sight-threatening stages, such as proliferative retinopathy and macular edema. One piece of good news is that in some parts of the world, like South and Central America and the Western Pacific, the number of people with retinopathy has actually gone down. That's largely thanks to better screening programs and improved access to treatment. But it's not the same story everywhere. In regions like Europe and Southeast Asia, the numbers have gone up, which really shows the gaps that still exist when it comes to access and how resources are distributed. Today, we'll unpack these findings with my guest, Dr. Rebecca Thomas, a leading diabetes retinopathy researcher from the UK. Dr. Thomas is a senior lecturer at Swansea University. She obtained her PhD from Cardiff University School of Medicine in 2015. Her PhD thesis explored the epidemiology of diabetic retinopathy and optimal screening intervals. Welcome to DTalk, Dr. Thomas.
Hi, thank you for having me. It's lovely to be here today.
In this episode, we'll look at what these numbers mean for the future and why only about 10% of people with retinopathy progress to the most sight-threatening stages. We'll also explore why some regions are seeing encouraging declines in retinopathy while others are experiencing increases, and what's driving these differences. We'll examine the UK's national screening program as a case study for success, discuss how AI and telemedicine are helping to expand access to eye care, and consider how to close the gaps in education, training, and treatment, especially in low and middle income countries. Most importantly, we'll talk about what governments and health systems can do now to prevent avoidable vision loss in people living with diabetes. Dr. Thomas, the 11th edition of the IDF Diabetes Atlas estimates that nearly 30% of people with diabetes have some form of diabetic retinopathy. And by 2050, 853 million people will live with diabetes. What does this mean for the future burden of vision impairment globally?
Well, it means that by 2050, we're expecting more than 250 million people to be living with some form of diabetic retinopathy. And a significant proportion of those, we're thinking 45 million, will have the sight-threatening form of the condition. That's going to be an enormous burden for society, for people living with this condition. Without access to affordable medicines, reliable glucose monitoring, systematic screening, and timely treatment, millions more will face avoidable vision loss. What's striking, to me anyway, is that diabetic retinopathy is often the first complication of diabetes to show itself. So it's the first one we can actually visualize in any part of the body, in any organ. If the small blood vessels in the eye are damaged, it is often likely that similar damage is happening elsewhere in the body as well. We're just not able to detect it yet. It's just that the eye is the only thing we can visualize at the minute. So the eye becomes a kind of a early warning system, and therefore protecting vision also gives us the chance to step in earlier and prevent other serious complications at the same time.
Thank you so much for that. I actually didn't know that the eyes were one of the first warning signs. So I want to share with you, Dr. Thomas, that when I was diagnosed, I didn't know what diabetes was or anything like that. And my eyes, I started losing vision in my eyes. But because I wear glasses, I thought, oh, it's that time of year to get an eye exam. And I got the eye exam. And when the glasses were ready, like 2 weeks later, I came back and the prescription didn't fit. And the guy was like, "Oh, yeah, like it's way off." So we did it again. Turns out, like 2 weeks later, I was in the hospital with DKA, and it took me like 6 months to get my vision restored to its normal. But I'm just wanted to share that with you as I'm really now leaving this podcast with information about like what happened to my eyes and how, because I already wear glasses, it detoured me from knowing that that's what was going on.
Yeah, it's amazing what the eyes pick up first. I've heard stories of the other way. So people who have had retinopathy, had their diabetes for a long time, had retinopathy, and had been through treatment for proliferative retinopathy, but then all of a sudden started seeing more changes in their vision, but because they'd already gone through treatment, assumed that it was the retinopathy coming back. So we're a bit too scared to go and find out. When in actual fact, when they did go and find out, they did just need glasses.
We know that sight-threatening diabetic retinopathy includes proliferated DR and central diabetic macular edema, but only around 10% of people with DR progress to this stage. Why is that? And why is early detection so critical?
So the development of retinopathy and sight-threatening retinopathy is very much linked to how long somebody's had diabetes for, how long they've lived with it for. So the longer someone has had diabetes, the greater the risk of retinopathy. So for somebody with, say, type 1 diabetes, after about 15 to 20 years of living with it, almost 90% of people will develop diabetic retinopathy. And for type 2 diabetes, it's about two-thirds. So about 60 to 70% would develop some form of retinopathy. Obviously, the sight-threatening form is less, but because type 2 diabetes can go undiagnosed for many years, some people already will have retinopathy by the time they receive their diagnosis. But progression of retinopathy is dependent on other factors as well, like high blood glucose, high blood pressure, ethnicity can predispose you to developing diabetic retinopathy as well, your genetics, and there's also other risk factors like pregnancy can speed up the development of retinopathy. So there are a lot of things that go into it. The good news is that progression of retinopathy is usually slow. It does take quite a number of years of high blood glucose damaging the retinal vessels before these severe changes happen. But the early stages cause no symptoms, so people feel fine. There's no pain, there's no visual signs, but the damage is still building up silently. And treatments like, we're lucky to have treatments for diabetic retinopathy. So the treatments like laser, photocoagulation, and anti-VEGF injections can prevent vision getting worse, but they rarely restore sight. So once sight is already lost, these treatments can't bring it back. So the sooner we detect these signs, the sooner we can act, the sooner we can do these treatments, the better, because the less sight has been lost. And in some cases, especially when we're talking about things like laser, they can damage vision themselves because they are a destructive process. And this is all why screening is so critical. It picks up the changes before your eyesight is affected. When these treatments like laser and anti-VEGF, when they are most effective, and we can actually use, in some cases, less laser, making sure that the least amount of damage is done by the treatment. And then obviously the other benefits, as we've said, is that spotting the damage in the eye earlier is a signal that maybe we could start changing other things in our diabetes management to make improvements and delay other complications, not just eye disease. So there's a whole person, whole body, whole organ benefit.
Well, thank you for sharing that. I just want to say, as a person living with diabetes, I love hearing that there are treatments for things because there's so oftentimes of like, there's nothing you can do. So, understanding that there are treatments available, that the screening is important because you can pick it up before the vision loss actually happens. And I'm just curious, like, can you explain how pregnancy impacts retinopathy? You mentioned that. Could you just give me a little bit more details on that?
What we see in pregnancy is obviously a lot of increased hormones and a lot of things going a little bit crazy. So the hormones being released can speed up the development of the retinopathy itself. But also what we see is that pregnancy is a time where mothers tend to protect their babies and they do everything they can to live healthier lifestyles. This includes improving their glucose management. And what we know is that if we do this too quickly, in some cases, that can cause progression of retinopathy as well. So it's very careful, but it's why preconception care before becoming pregnant, if you have diabetes, is so vitally important.
Going back to the IDF Atlas, the Atlas highlights regional variation in diabetic retinopathy trends. Some areas are seeing decreases while others are experiencing increases. What factors explain these opposing trends, and how should this inform policy and resource allocation?
There are large variations, and they are influenced by lots of different things. So, in places like the UK, where we now have national screening programs, this has transformed our outcomes. Rates of sight loss from diabetes have fallen dramatically, and that shows what is possible when governments invest in systematic prevention of conditions. But we also need to be careful when we do interpret these prevalence figures because it depends on the populations they're looking at, and it also depends on how they are detecting the diabetic retinopathy as well. So if we're looking at studies that are looking at populations within a hospital setting, we will naturally show higher levels of disease because those people who are into the hospital often are symptomatic and they also have the means to travel to the hospital. So if you live miles away from the hospital without a car or a bus or any form of transportation, you're not going to be able to get to the hospital to appear in that data set in the first place. So while those who do attend the clinics often have more advanced disease in the first place, so hospital data can overestimate prevalence compared with other studies which may be more community-based, population-based screening settings. The way we detect disease also makes a difference. So some studies that we looked at used handheld cameras or smartphones. Obviously, they're easier to transport in, more rural settings that are more difficult to access. But they do provide a smaller field of view with a poorer image quality compared to sort of the larger, more established wide field cameras that we might see in the hospital setting. And so they may themselves underdetect the retinopathy that we see. Then there are some studies that include or exclude ungradable images, and these can shift the figures some way as well. But in reality, very few studies achieve the gold standard of true high-quality prevalence research, which would mean probability sampling across whole populations, good participation rates, consistent imaging and grading, inclusive techniques to make sure that we capture the full population. Examples like the Singapore Pioneer Study or Australia's National Eye Health Survey, which use stratified random sampling and mobile clinics to reach really remote participants, show what high quality epidemiological studies can look like. But they are really still the exception rather than the rule. The Atlas itself highlights how all of this can play out. So prevalence appears to be falling in countries like the US and China, but rising in India, while rates vary widely even within regions, as high as 50% in countries like Iraq and Bhutan, but they are under 10% in countries like Iran. So these differences reflect not only the biology and the population at risk, but also the study design, access to care, the tools used for screening. On top of that, ethnicity does play a role. So people of South Asian and Black descents, they are at higher risk of both developing diabetes as well as the complications of diabetes. So there is quite a variation in the studies that we looked at for the Atlas. And the lesson for policymakers would really be one size doesn't fit all. Each region really needs tailored strategies that reflect its resources, workforce, population, investment in screening, training, affordable treatment. It all needs to be aligned to the local realities of the situation on the ground. And as a scientist, we do need to do better as well. We need to make sure that we are conducting and reporting high quality prevalence studies so that we can truly understand the magnitude of the problem. But all of this is going to require a lot more investment from funders if we're going to do proper epidemiological research.
I hope they're listening because we need the funding. I love what you said about the local realities and the tailored strategies. That is so, so, so very important because the same information could be told to two different groups, but one group's grasp it better than the other for whatever reason. Interestingly, the 11th edition of the IDF Diabetes Atlas reports a slight decrease in the overall prevalence of any diabetic retinopathy compared to earlier editions. How do we explain this? Is it because of better screening programs and early treatment uptake?
I would love to say that this reflects real progress. I really, really would. And there is some evidence that, better diabetes management and earlier treatment are making a difference. So studies in the US have shown a decline in sight-threatening disease over time. But we do really need to be cautious. For the Atlas, we combine data from many different studies, and they had differences in how they measured retinopathy, like I just said. And which countries contributed to the data between the different versions of the Atlas. And all of this can really influence the overall picture. So interestingly, while the overall prevalence, as you said, dropped, so it fell from 27% down to 23%, the prevalence of proliferative retinopathy, which is the real, sight-threatening form of this condition, actually increased. It was 4 times higher, rising from 1.4% to 6%. So it's progress in one sense, but a warning sign in another, and definitely paints a not straightforward picture, especially when you take into account the issues that I mentioned before about the quality of prevalence studies. But what we can say for definite is the burden remains huge, and we need to keep building on these prevention, early detection, and effective treatment strategies everywhere to make sure that everybody has access to this healthcare.
When you talk about the early treatments, I know that you've been a part of a program that I'd love to get into now. So, if we could just let's take a moment to look at the UK. The national screening programs have transformed the landscape. In fact, systemic eye screening coupled with improved diabetes management has reduced DR as a leading cause of blindness among working age adults. Screening intervals for low risk individuals have even been safely extended to 2 years, freeing resources for higher risk patients. Dr. Thomas, can you share how this model can inspire global approaches, especially in lower resource settings?
This is something that is very near and dear to my heart because I was involved in the Welsh screening program right from its start all the way through. And obviously, as you mentioned in the introduction, my PhD thesis was around this as well. So this really is a big success story, really. The UK is a great example of what systematic screening can really achieve. When it was first introduced, the experts, so that's the UK National Screening Committee, they predicted that we could cut diabetes-related sight loss by a half within 5 years. And it's exactly what happened. The UK was a pioneer in systematic screening, and this effort has helped move retinopathy down from being the leading cause of blindness in working age adults. So that's 16 to 64-year-olds. And that's a real powerful proof of concept that this actually works. Yes, we have to recognise it's expensive. Systematic screening, the investment in staff, the workforce training, the equipment, it is expensive to set up, but it does save money in the long run by preventing blindness and all of those social and economic costs that come with it. A key feature of the UK programme is its workforce that a lot of people don't really understand. Screening in the UK isn't done by our doctors. It's not done by ophthalmologists. It's carried out by trained photographers and graders who are skilled at recognising early disease. And we only actually refer those people with serious sight-threatening retinopathy to the doctors and the specialists. That means that our ophthalmologists focus only on the people that actually need the treatment. The screening only works if a treatment is available. There is absolutely no point in identifying people with sight-threatening retinopathy if people cannot access the treatment. So lasers, anti-VEGF injections, steroid implants, surgery, or the trained professionals that are needed to carry out these treatments. And equally, good access to diabetes medicines and glucose monitoring is essential to stop retinopathy progressing in the first place. The real lesson is that prevention, detection and treatment, they all have to go hand in hand. You can't have one without the other.
Can you just clarify for me, like if I decided to move back to Wales where I was engaged and I wanted to get my eye screening, where am I actually going? Because you said it's not the ophthalmologists that are doing it. So like where am I going to get the screening?
So we are very much a community-based screening program. So our graders, our screening teams go out into the community. So you're referred in to us by your primary care physician in the first place. And then we have clinics set up in a variety of settings. So you will find our clinics in hospitals, in the outpatients departments, in GPs, in primary care clinics. We might also use community centres, village halls, wherever we can get the space that we need and the environment that is suitable for these. So we really do try and go out into the community. In Wales, for example, we have over 200 clinics sites that we would use. In the past, we've used mobile vans as well. So big screening vans will go out and sit in a car park, for example, and you'll come onto the mobile vans and you'll have your eyes screened in the van itself. So.
Oh, wow. I absolutely love community care because it's always accessible. It's like right between my walk, wherever I'm going to dinner or lunch, I can actually get screened. Thanks for sharing that information. Now I'm going to reach out to my friends that I met in Cardiff just to see if they've actually gone through the screening and encourage them to do so if they haven't. Cataracts and glaucoma are also more common in people with diabetes, but diabetic retinopathy dominates the conversation. Why do you think that is, and how can we raise awareness of these other diabetes related eye conditions?
The high blood glucose that we see in diabetes, this doesn't affect just the retina or the back of the eye. It also affects the front of the eye, so the lens and the drainage system in the front of the eye that we have. This makes people with diabetes more susceptible to developing cataracts and glaucoma. The difference is diabetic retinopathy is a direct complication of the diabetes. It is directly because of the high glucose, whereas cataracts and glaucoma happen in the general population anyway. So whilst people with diabetes are at higher risk, this is something that goes on for everybody. So everybody can develop cataracts and glaucoma without diabetes. So that's probably why retinopathy dominates the conversation, because actually in normal eye care settings, cataracts and glaucoma would dominate the conversation there, because far more people would go in with those conditions than they would with a diabetic retinopathy. But I think that's why in diabetes, we tend to just focus on the retinopathy. And it is the most common microvascular complication of diabetes. And whenever anybody surveys people living with diabetes, it is one of the most feared complication out there as well. People really are fearsome of losing their sight and the independence and the life changes that have to come with that. But I think it's important that we raise awareness amongst people with diabetes about all the conditions that they're at risk of, and that as well as having regular screening with diabetes professionals, they should also be having eye exams. So in the UK, that would be with our opticians, optometrists. They are very much part of the system where they look after all the other eye complications and we look after just the diabetic retinopathy. So in the UK, screening works very much alongside routine optometry, but I realise that that's not the case everywhere. And I have seen firsthand the impact and how life-changing it can be. I was in Tanzania a couple of years ago doing some screening work there, and we were quite rural, so there wasn't very much access to eye care. And a man came in for screening. He was nearly blind from cataracts. And just days after surgery, he was walking confidently around the village on his own. And it was such a joy and a pleasure just to see the smile on his face and to see it. So it has a profound effect on people's lives. So while retinopathy rightly gets the attention within the diabetes world that it should, we shouldn't forget the other complications that diabetes makes us more likely to develop.
Thank you for sharing that. And I'd like to further talk about the various screenings. So you talked about the UK, you talked about Tanzania. Screening policies for diabetes related eye disease varies across countries, as you just mentioned. What does the Atlas tell us about the impact of screening programs like the UK's biennial model, and how might telemedicine and AI support early detection in these underserved areas?
Screening programs, like I've said, they make a huge difference, and the UK is a great shining example. But not every country has the resources to replicate a national systematic program like the UK has. And I think that's where telemedicine and AI could really be a game changer in this space. Telemedicine allows images to be taken remotely within community clinics and can be graded by specialists that are located elsewhere. So the specialists don't have to be there, but the pictures can be taken within those community settings. AI is becoming very good now at identifying the more severe sight-threatening stages of diabetic retinopathy. So that means that it can help flag people who need the treatment more quickly and potentially at a lower cost, especially in areas with limited workforce. And I know that this is already being used in countries like India. They're already using AI and handheld cameras to try and access those community and remote settings. But there are challenges with AI, though. It depends on internet access, being trained with diverse data, representative data. But the potential for it is enormous. Looking ahead, I think we'll see retinal imaging being used not only for eye disease detection, but also giving us insights into other systems within the body. So cardiovascular, kidney, dementia, possibly. The eye truly is going to become a window to overall health and could impact beyond eye care in general.
Thank you so much for talking about the use of AI and the wonderful things that it could do, but then also how we are the humans that train AI and it needs to be diverse. I'm going to share with you recently there was this study. I shall not get into the details. I don't want to call them out. But I was so enthralled about like being part of that study because I am one of those people that feel like if I can help further our knowledge, I want to. But they cut off. It was like first wave of trying this thing, and they cut it off with the weight. like BMI, and I'm a person that lives with obesity. And this was literally like a 2 kilo difference. And I'm like, I could lose 2 kilo in like 2 months and I'm still the same person, you know? And I just often wonder about how things like obesity, things like ethnicity, like affect these progressions that we have. So again, thank you so much for pointing out that we need to consider these kinds of things as we're advancing technology.
Definitely. That it is really important to make sure, especially in these data sets, a lot of them are being trained in countries that are with data that is predominantly white ethnicity. And we just need to make sure that they are tested in other diverse groups and that we don't just pick them up from one setting and assume they're going to work in another setting, because they don't. There are differences. The eye is different. So we do need to make sure we train these things on as wide a population that we can. I'm very passionate about inclusive research and inclusive recruitment practices to make sure we get as wide a population within our studies as possible.
We definitely need more inclusivity. Despite the progress, the Atlas points to shortfalls in patient education, professional training, and treatment access, especially in low and middle income countries. What steps should the global diabetes community take to close these gaps?
Yeah, so there was a really big study called the Barometer study, which was looking at diabetic retinopathy. And they found that nearly half of people with diabetes worldwide didn't even know that diabetes could cause blindness. And many couldn't afford the treatment. They didn't have access to affordable treatment. And that is just shocking to me. The gaps definitely need to be closed on this. It is just crazy. So I believe we need three fronts of action for all of this. First, and most importantly, we need patient education. People living with diabetes need clear, culturally relevant, language appropriate, age appropriate information so that they can understand why eye checks matter and how they can protect their sight. Second, we need professional training. So we need to build a skilled workforce that is critical. That means investing not only in our doctors, our ophthalmologists, but also in nurses, optometrists, photographers, graders, a wide section who can deliver early detection and treatment and care as early as possible. And then third, we need to make sure we have access to treatment because, detecting these things is great, but if we can't treat, there really is no point. So, and also, access to medicines for diabetes as well is so important. So access to treatment is a really big thing. Medicines, technologies, screening tools, all of these must be affordable and available everywhere. International partnerships can really help, whether through the telemedicine that we just talked about, and shared training, reducing the cost of essential drugs and equipment. The bottom line is that where someone lives should not determine whether they lose their sight due to diabetes.
I have one more question to ask you, but I just want to say that is a ball drop for me. I am like snapping fingers and clapping my hands. Yes, yes, yes to everything you have said, Dr. Thomas. But to stay on track, this is my last question for you on this session, and I'd love to have you back for a part two. If you could give one piece of advice to governments or health systems to protect people with diabetes from vision loss, what would it be?
My main point is invest in prevention. Sight loss from diabetes is avoidable, but only if people have access to screening and timely treatment. And right now, fewer than 10 out of 53 European countries have universal screening coverage. So that shows just how far we still have to go, even in high income regions. These measures are not just cost effective, they save health systems money in the long term while protecting people's independence and quality of life. No one should lose their vision to a condition we already know how to prevent.
Dr. Thomas, thank you so much for joining us and sharing your wonderful insight. As a person living with diabetes, I'm definitely going to make sure that people know about the treatment options that exist. I want people to know that it is something where you don't have to just simply lose your vision, that there is, in fact, hope, which is so important in our community to just know that there is hope.
There's hope, and I think one other thing that people, they're not alone, and it's not your fault. So, like I said at the start, 90% of people with type 1 diabetes will develop retinopathy. You're not alone, and it's also not your fault. Living with this condition is relentless, and developing complications sometimes seem inevitable, but we can delay them and slow them down, and there is treatment. So I think there's still a lot of hope, and you're not alone.
The IDF Diabetes Atlas makes it clear diabetes related eye disease is preventable, but only with early detection, equitable access to care, and integrated health strategies. Programs like the UK's prove that systematic screening saves sight, yet many regions still face significant gaps in access. To our listeners, if you live with diabetes, please schedule regular eye screenings, even if your vision seems fine. And for policymakers, prioritize diabetic eye care in national strategies. Sight loss from diabetes is preventable, but only if we act promptly. I'm Phyllisa Deroze, and this has been another episode of D-Talk. Thanks for joining us. We'll be back soon with more insights from the global diabetes community.